Oh, God, those lights are bright. Sorry, I don't have a laptop, so I will have to turn and look at my slides every once in a while. So we're going to talk about the journey to and through lung transplantation. And this is the best quote that I've ever read, that when you can't breathe, nothing else matters. So who do we get referrals from? Respirologists, cardiologists, internal medicine doctors, and we will even accept referrals from GPs if people live in remote communities. Our referrals come from BC and the Yukon, and patients from other provinces that will be moving to BC. And sometimes if their family support is in BC. What types of patients are referred? Cystic fibrosis, COPD, emphysema, alpha-1, pulmonary fibrosis, pulmonary hypertension, bronchiectasis, and then some other kind of rare diseases. So kind of the percentage of patients that are being referred. Pulmonary fibrosis is now becoming our biggest patient group that are being referred. COPD, which includes the alpha-1s, pulmonary hypertension, cystic fibrosis, and then other lung diseases. Referrals are received and registered through our Promise database with BC Transplant, which is also linked to the Canadian Blood Services. Canadian Blood Services has the transplant registry, so when patients are listed on the list, they're with Canadian Blood Services. So information is reviewed and for the required information. So history, PFTs, CT scans, we don't require a lot. We will move on from there. Triaged by myself and the doctor so as to priority how soon do patients need to come in to see us. Some are more urgent than others. Some actually just get admitted right to the hospital. So your initial appointment, you're seen by myself. I give you guys a questionnaire to fill out beforehand, and we review that. And I give an overview of the lung transplant program and given a review of the assessment process. Then seen by one of our transplant respirologists. They do a history and physical, and then they determine suitability for transplant. So that first appointment, we make the decision as to whether or not we go forward with assessment. Is it urgent? I have literally walked patients over to the ER to get them admitted into the hospital so that we can start an assessment. Regular assessment is done as an outpatient. And now the fun begins. So this is how easy the patients think it is in the in and out lung transplant, but it's not. This is our assessment orders, and that's page 1 and page 2. So we do a lot of testing. So we do a lot of blood work, 19 vials of blood, sputum, urine. Radiology, so we do x-rays, CT scans, abdominal ultrasounds, VQ scans, bone densities, carotid Doppler, cardiology, so ECG, echo, and we do a right and a left heart cath. And then follow-up testing to anything that we found. And I'm always calling patients saying we need just one more test, or we need to send you to one more doctor. So we are not looking for things to say that you can't have a transplant. We're looking for things that we need to deal with before you have a transplant. Once all the medical testing is done, then you meet with the other team members, so a dietitian. We require a BMI less than 32 for listing and prefer patients to be under a BMI of 30. They're met with a psychologist. What are their coping skills, compliance, family dynamics. Social worker will talk about finances and social support. Social support is probably the biggest thing, and it's our biggest challenge when people don't have a lot of family members, are divorced, estranged from families. If there can be no identified social support, we cannot offer a transplant. This is not something that you do alone. We all want it to be easy and a breeze, but sometimes there are challenges. And then meeting with anesthesiology. Unfortunately, we're so busy, our surgeon is so busy that only complicated cases will meet with the surgeon until the time of transplant. He will always meet with them the day of transplant. Once all that is done, return to the clinic. We'll review all the test results, and then it's what does the patient want to do? Because sometimes at the end of all of this, they say, we have heard everything that you have said. This is not for me. This is not for me right now, or let's move forward. We review all the cases at rounds with all of our team members, and we make a decision to activate or not. So then, if transplant is not an option, they're discharged from the program, or we continue to follow them. So sometimes it's like transplant too early, and then we will follow patients every 6 months or so and see how things are progressing, or they're activated to the list. So when you're activated to the list, I talk about what happens behind the scenes. So our donors come from throughout BC, sometimes the Yukon, sometimes Alaska or Washington. We will share. Things go on 24, 48 hours before we make decisions. So it's not like Grey's Anatomy when you get that phone call. The lungs are not sitting there waiting for you. It's a little bit of a hurry up and wait. We get you in as soon as possible, and then you sit there and wait for 12 hours. So when the call comes in and stuff. So here are some pictures with a lung transplant. So on the left is a native lung with end-stage emphysema, and you can see kind of the blackness of it from smoking environment. And then on the right, the nice pink lung after donation. They use a clamshell incision, so it goes across the front of your chest, and they open you like a clam, so you can see the patient's head at the top. And they take one lung out and put one lung in, and take one lung out and put one lung in. Surgery is about 8 hours. The surgeons like to high-five themselves with the COPD patients that they can do it in 4 hours. Those lungs like to pop out. So what is new in 2018 with lung transplantation? So the old lung transplantation, it was a surgical procedure. We were looking to preserve lungs. Donors had to be, they were young, good lungs, good donors, working on avoiding acute rejection and focus on survival. Now we look at it as a medical procedure. We are using extended donors, extended recipients, looking at changes in immunosuppression, avoiding infections, and chronic lung allograft dysfunction, quality of life. What can we do to use as a bridge to transplant? Donor lung reconditioning and lung bioengineering. So what do higher volumes mean for the patients? Sorry, can't really see it. We're trying to increase our donor pool numbers and stuff, and what do the higher volumes mean for the patients? So what are the contraindications to lung transplants? Absolute is any kind of malignancy in the past 2 years, advanced dysfunction of other organ systems, so renal failure, cardiac disease, non-curable chronic infections, significant chest wall deformities, and then ability to follow the medical regime. And that is a big thing if you're not someone who can cope with having to do something lifelong, because transplant is a lifelong commitment. Relative contraindications, this used to be, our criteria used to be that we didn't transplant anyone over the age of 65, limited rehab potential, obesity, colonization with highly resistant and virulent organisms, and then someone being on advanced life support. So if you were intubated in the ICU, we could not offer a transplant. Connective tissue disease, HIV, and critically ill patients. We're now pushing those borders as well. We've actually done 2 patients that have been HIV positive. So the timing of referral for lung transplant. So rarely is it an option for an acute respiratory failure. What we don't want is a phone call saying, so-and-so's in the ICU, intubated in the ICU, can you give them a lung transplant? It's not going to work. We want patients that have less than 50% 2 to 3 year survival. We know that lung transplants don't last forever, so we want to do it in the best window of time when people can get the best benefit from a transplant. And then also having that ability for them to wait on the list before dying. So wait times can be variable. Height, blood group, larger and smaller individuals, and longer for blood groups other than ABs. So certainly, if you're 5 feet tall and an O blood type, we know that you're going to wait longer. And some diseases don't survive as long, so pulmonary fibrosis, pulmonary hypertension, CF, versus COPD and congenital heart patients. So what are the evolving recipient indications? So age, we're pushing that. We now will transplant up to the age of 70. We have done patients that are HIV positive. Connective tissue disease, because we know that that's an ongoing thing. Patients with esophageal dysfunction. When it's the problem of swallowing and aspirating into your new lungs, and patients that are critically ill. So we need a compatible blood group. We need a size match. We need the immunology match. And that 15 years ago, we didn't even worry about that. Now it's a big concern. How do you have antibodies? You have antibodies from having babies, having blood transfusions, from having infections. The test results will give us a percentage. What we want is 0. We have patients that are 100%, which means they will have donors against 100% of the population. And so we are trying to find the antibodies that we can cross. And who will have, so the urgency, who will have the net benefit from a transplant? And then recipient time on the wait list is the last kind of factor. People always call and say, where am I on the list? And I say, you're number 1, you're number 40, and you're every number in between, because with each donor, we start the process all over again. So this is from CORE, organs required by Canadians in 2014. And you can see the lungs that there's 300 people, sorry, I have to come over here. So the yellow is the transplants, the green is the people waiting, so 300 people waiting, and that 70 people died on the list waiting for transplant. And we typically say that we will have about 30% death on the waiting list every year. Organ donation in Canada. Sorry, this is a really hard one. So the black line is the number of transplants that we do, and the upper line is the number of people waiting for transplants. Sorry, I can't see these ones from here. So this one is all transplants, with the black being deceased donors and the white being living donors, so that would be for kidneys and livers. BC is making huge strides in the number of donors, the percentage of donors that we're getting. So, what is it, 2005, we were 5.8, and now we're 15. So certainly, the organ donation has become much higher. So what are we doing to increase the donor supply? Extending donors. In some, they're looking at ABO incompatibility, so giving a different blood type. The traditional is that they have to be the blood type. Similar size match. A donor had to be less than 55 with limited smoking, no known lung disease, no major chest trauma or infection, minimal pulmonary secretions, clear chest x-ray, and then a POT greater of 13, HIV negative, Hep B negative. So here are the things that we're now kind of pushing when we have donors. So what have we been looking at? Living donors, xenografting, donation after cardiocirculatory death, DCD, and optimizing donor lungs. So they looked at doing lobar transplants. Typically it was for very small adults or CF children, where they would take the lower lobes from 2 people and give them very small lungs. And as you can see, it rarely is being done now. It didn't kind of have the desired outcome that they expected. They talked about xenografting, taking pig lungs and putting them in. The best quote that I ever heard was that xenotransplant is the future of transplant, and it will always be the future of transplant. Donation after cardiocircular death, DCD. So our typical donor is a brain-dead donor. We now are doing donors that are not going to survive their injury, their event, and they are taken to the OR and removed from the breathing machine, and they have to pass within a certain amount of time. And then we will harvest the organs. And the best thing is probably optimizing donor lungs. I always said that we were the Charlie Brown of transplant in that, you know, it's like, oh, we're getting kidneys and we're getting a liver and we're getting a heart, and I'd be like, I'm getting a rock. Because certainly when these patients are brought into the hospital, of course they're trying to save their lives, and they are trying to save their brain and their kidneys, and often the lungs would get flooded out and stuff. So often we didn't get lungs, but they are certainly doing more, that we get more lungs from donors. And what are we doing to optimize donor lungs? We don't have it yet here at Vancouver General. They tell me it's coming soon, is ex vivo, the lungs in a box. So they will take lungs that we would normally not use And because they don't have a brain or kidneys attached to them, they can hit it with 40 times the antibiotics and try and make these things better. So we have a donor, we assess, we either reject, transplant. Now we observe, we assess, we reject, or we transplant. So the donor pool, the top part is the ideal brain death donor. We are now doing extended donors, DCD donors, ex vivo. And so this is the thing, is that they're now treating the lungs better. So there is your ex vivo. So, they perfuse it, they do drugs, biologic, cell therapy, gene therapy. I mean, we don't have it yet. We're coming soon. Toronto has it. Edmonton has it. And that's what it looks like in the box. And it's quite amazing. I wish I could have had video, but to actually see these things breathing inside of that container. So the transplant window, we always talk about the transplant window. Someone's too early and someone's too late. And so that is that, we want that little window of time where they will do the best from transplant, they will survive to transplant, and sometimes we don't get that window. We're talking about bridge to transplant now. So what are patients that we will do extra measures on? So this is ECMO, and it takes over the work of the heart and the lungs, and patients are awake, they can exercise. This is our patient Willie. He was the first one that we did ECMO on. He had pulmonary fibrosis that was rapidly deteriorating, and so we put him on ECMO, so you can see that he's alive and awake and able to communicate. There are his kids playing the violin to him in the ICU. The top left is Willie with post-transplant with Dr. Yee and our two ICU physicians. And Willie and his family now. This patient, it was our longest surviving. She just actually died this year of breast cancer. She was a CF patient who got transplanted before we even had a transplant program. She went to England. She was in her 30s when she was transplanted. And at that time, transplant was, they did a heart and lung block. Because she was young, her heart was perfectly fine. They dominoed her heart into a man from Greece who lived 17 years with her heart. Post-transplant, so after you've been discharged, you're seen in the transplant clinic twice a week for the first couple of months. Days start early. Wednesdays, I come in at 6:30 for rounds, and there is already a lineup of patients outside the lab because they want to be the first. So you come in and you do blood work and a chest x-ray and do spirometry. You're seen by the nurse and the respirologist. Changes are made to your medications based upon your results. You have bronchoscopy at 6 weeks and 3 months. Patients do home spirometry. We give you a home spirometer. That is your first indicator of rejection. If you're seeing those numbers drop, 10%, you need to call the clinic and get in. I think things kind of got out of sorts here. So why are we having an increase in lung transplants? Because we have better ICU identification of potential donors, trained in-house requesters, increased experienced transplant teams, so enhanced peri-transplant support options. So the ex vivo, the ECMO, improved diagnostics to aid in risk profiling, NAT testing. So this is for Hep B, Hep C, HIV in donors, and then donation after cardiocirculatory death. Certainly the fentanyl crisis has gotten us lots of donors. Last year it was amazing how many donors we had from this, and it continues. So the improvements in lung transplant give better access to lung transplants. We can do more elective patients as compared to, and then also the high urgency patients with broader indications. So we're increasing the age of recipients, patients with connective tissue disease, esophageal dysfunction, and those that are critically ill. We're getting more organs and better quality organs and increased safety and better outcomes for the recipients. So this is data from the ISHLT, so the International Society of Heart-Lung Transplant. So the procedure type, so you can see before we were doing more singles and now it's becoming more double lungs. And that, especially in COPD, we always did a single lung transplant. Now, of course, we know that the hyperinflation continues, and the native lung was squeezing out the transplanted lung, so we're doing more double lung transplants. The transplants, and this is worldwide, so you can see that COPD is about 40% of transplants, with alpha-1 being 4 to 5% of that. And so the first column is alpha-1, where it was kind of half and half, double versus single, and now you can see in 2016 that we're doing more doubles for alpha-1. And same thing, so that the red is single lung transplants, the blue is double lung transplants, and that is increasing. Survival for patients for their first transplant. That the median survival is about 7 years, single lung about 5 years. But if you look at it in eras, that certainly things are getting better. So the blue line is kind of the first decade of it, the green line the second, and the third is now. And so you can see that their survival is getting a little bit better. Gender, sorry guys, women do better. And then survival by diseases. So the red line, so green is COPD, and you can actually see that, you know, over time COPD is kind of at the bottom, but red is the alpha-1. So alpha-1 does a bit better over time, and this is, you know, now going out 21 years. And then conditional, so that you survive the first 3 months of transplant, and then how you'll do over time. And once again, kind of alpha-1 is in the middle of the road there. And then conditional on survival up to the first year, and then how things go. And now you can see that double has a better survival than single lung transplants. And this is for COPD. So once again, double has a better survival than single lung transplants. the morbidity rates in survivors within 1 year. So certainly kidney dysfunction, diabetes, and bronchiolitis obliterans syndrome, which is kind of chronic rejection. And you can see that that's improving kind of in the new era. So increased donor organs means that there's a decreased need for having to do urgent transplants, that patients were hoping to lower death on the wait list because patients will not be so sick. And you can see that that's now blue being kind of regular transplant, the pink urgent, and the red being the high urgency. This is our BC, this is VGH's stats. So this goes up to 2016. So you can see with the light blue being DCD donors when we started doing the donation after cardiocirculatory death. But you can also see the numbers, how they're increasing, that we're getting the number of more donors and the number of transplants. And last year we actually did 52 lung transplants for 2017, and we have so far done 40 this year. And this, once again, is kind of the referral of patients. So pulmonary fibrosis now being the biggest one. So COPD kind of in the purple, and then the light blue is the alpha-1. So it's a small part of our program, although I think sometimes in the beginning it wasn't actually, people weren't actually identified as alpha-1 or got grouped into the COPD. And so of the referrals, this is the patients that are being transplanted. So we transplant about 5% of our total transplants are alpha-1s. Our median survival for first single and double lung transplant. So the blue is, the dotted red line is all patients, green being the single, and the blue is the double. So you can see that our survival is quite good. And we're quite proud of this, that we're actually above the Canada average. The median survival in Canada is 7.6 years, and for us it's 10. Sorry, that's a small slide. And so, double lung transplants by era. So you can see that in the first area, the pink line, how the survival is and quite low. The blue getting better, and now green is kind of the last 10 years, and how our survival is getting better. And the survival of double lung transplants in BC versus Canada. So we are approaching about 75% 10-year survival. This is our little lung transplant team. That's it, minus the nurses in the ICU and on the ward and the doctors in there. And one day that we hope that we are celebrating the anniversary of your lung transplant. Thank you.